got 125 people on tonight's call, and that's lovely to see you all. So I'm going to start properly now. So hello, good evening, everybody. I'm Cathy Yelf, the Chief Executive of the Macular Society, and a very warm welcome to tonight's Macular Society virtual clinic. Once again, I am very grateful to all the world-class clinicians and researchers and scientists who are willing to give their time to take part in these events. We've been running them, as you may know, since the summer of last year, mainly in response to the lockdown and the pandemic, and of course our inability to do any of these sessions face-to-face as we might normally want to do. But they have been such a success that I think we will keep them going forevermore now. So thank you for joining us once again. If you have any questions this evening, you can use the chat function, and I will read your question out for you during the question and answer session later. Some people have already submitted questions, and we'll try to get to as many of those as we possibly can in the course of the next hour. So tonight's topic is a new for wet AMD called Beovu. This drug has been developed by Novartis, who also created Lucentis, a drug that many of you will already have been familiar with. It works in a similar way, but it's designed to last longer, and so has the potential to reduce the number of injections needed to maintain vision. And as I'm sure you'll appreciate and know only too well, that would be a great step forward. So what is Beovu, and is it as promising as we hope it is? My guest tonight is Professor Faruque Ghanchi from the Bradford Teaching Hospitals in Yorkshire. Faruque is a consultant ophthalmologist who specialises in retinal conditions such as AMD, and he is also head of the Bradford Ophthalmology Research Network. He's the clinical lead in his area for ophthalmology, for AMD, and he's the national vice chair of the NHS's own research body, the National Institute for Health Research in the ophthalmology section. He's been leading some of the clinical trials into Beovu, which is why we have asked him and he has very graciously agreed to join us here this evening. So I'm going to hand over to Faruque, who's going to tell us more about Beovu, and then we'll come back to your questions a bit later in the session. So Faruque, thank you very much indeed for joining us this evening, and I'm going to hand over to you now.
Thank you very much, Cathy, and thank you very much, Macular Society. To me, Macular Society is like a family. I've been working in the field of macular degeneration for quite a few years, almost 25 years, as a trainee first, and subsequently as a consultant. And I've been associated with Macular Society for a while, and naturally with our local body here in Bradford that have been very kind to me and inviting me to their meetings at least once a year. So it's been a fascinating journey for us all together in finding better answers for these difficult situations like macular degeneration that our patients face. Macular Society has been very supportive of research in this field and helping us to find better answers, as I mentioned earlier on. So as Cathy says, I'm one of the ophthalmologists here in Bradford. And if I give you the background, when I was appointed here at the turn of the millennium, I was one of the first medical retina consultants. And now we have 7 medical retina consultants in Bradford. And that shows how much progress that has been made in how we can manage macular conditions better. There are more options that are available to us, and we can treat a lot more patients. And that is the essence of the talk today. We have yet another option for treating wet macular degeneration with another very promising agent called Beovu. And I'm going to talk to you about that, if I may, over the next few minutes. And then I will be happy to take your questions and comments and see how we can do better for all of us, our patients, and our systems in the NHS. I'll share some slides with you. There are not many, but it just helps me to remember what would be the important points to make, if I may. So I'm sure we all know about the eye and the macula, but just to recap on that, when you go to the clinics, in the macula clinics, and your consultants or the doctors or the optometrists talk to you with the pictures of the macula, it doesn't look anything like the eye that we see from the outside. So if you remember, the inside, the inner wall of the eye is lined with a layer called retina. That's like the wallpaper in the rooms. And the wallpaper is stuck on the plaster that is the middle layer of the eye. And that plaster or the middle layer of the eye is made out of some loose blood vessels, capillaries. And those capillaries in the middle layer or the plaster layer are quite leaky by nature. But there is a barrier between the plaster layer and the wallpaper that keeps that fluid away from the retina. Now, the other thing to bear in mind is the macula, which is the very central point of that wallpaper where we have the best vision. And the vision is picked up by the receptors, like the touch receptors in our skin. There are light sensitive receptors in the retina. There are two types, cones and rods. So in the macula, it's mainly the cones which give us the best or the precise vision. That helps us to pick up the form, the smallest print, for example. It also helps us to pick up the contrast. So that's how we can recognize faces, differentiating contrast between the eyebrows and the eyeball and the nose and the lips. And that helps us to figure out whose face it is. And that is served by macula. And the third important function of the macula is the color vision. So most of the color vision is the central part of the retina, the macula. Further out we go from the macula, the rest of the retina gives us the side vision and very good night vision, actually, with the rods sitting there. So if the macula gets into trouble for whatever reason, all those three parts of the vision, that is the form vision, small prints or finer details, contrast, and the colors get affected. And what we're talking about today is macular degeneration, that is age-related wear and tear in the retinal tissue in that central part called macula. Now, over the years, the photoreceptors keep on working, telling us what we are looking at in the outside world. But that process requires the vitamin A in those receptor cells to be used up, then processed and cleaned back and recycled back in the photoreceptors. And in that process, over the years, some debris gets collected under the retina, in the deeper layers of the retina, and that is the earliest change of macular degeneration. And in that stage, there is no fluid in that area. It's just simply worn out tissue and the debris collection, something that we know as dry macular degeneration. Now, to me, macular degeneration is just one continuous process. Everybody gets more or less the same changes in the retina. 80% of the patients with macular degeneration would stay in the dry form. About 10 to 20% happen to change into what we call wet macular degeneration, where the fluid from the capillaries under the retina, that's the middle layer, starts growing in and starts leaking fluid, causing that buildup of fluid under the retina or within the retina. Because there is fluid at that stage, we call it wet macular degeneration. Now, there are various scientific theories as to why that happens. But one thing we have figured out for sure is that the blood vessels require kind of a chemical to start growing. And that chemical is known as VEGF, VEGF, which stands for vascular endothelial growth factor. So with the excess production of that VEGF, we have these new blood vessels or capillaries growing under the retina. It's kind of a fertilizer for the blood vessels to grow with. And hence, with the trials that we had done back in late 90s, early 2000, in blocking the VEGF, this fertilizer, to see if it stops the blood vessels growing. And we found very quickly, not only it stops the leakage, it also stops the blood vessels from growing further. And unlike the previous treatments that we had for macular degeneration, especially the wet macular degeneration, namely the laser, the hot laser or cold laser, blocking this fertilizer or mopping it up with these extra injections called anti-VEGF were very efficient in controlling the wet macular degeneration. And because it works very quickly, we were able to improve vision in a number of our patients over the years. So anti-VEGF injections, namely Lucentis and Eylea, have been the standard practice now for treating patients with wet macular degeneration. So you may have heard that people talk about macular degeneration as the leading cause for vision loss or blindness in Western world. But since the advent of these anti-VEGF injections, there has been a significant reduction in blindness caused by macular degeneration. A recent paper that's published shows that almost 30% reduction over the last 3 decades in the incidence of blindness from macular degeneration, and that is attributed to these anti-VEGF injections. So what happens is, say, if you go to any clinic and if you have macular degeneration identified, you would have pathway similar to what we follow here in Bradford, that you would have assessment of your vision first, and then you would have a scan of your retina. That's called OCT scan for short. And that gives very detailed picture of your retina, almost looking like a picture under the microscope of the retina. And that tells your clinician whether there is fluid leakage or not. And you would have an assessment by the doctor or the optician or the nurse in the clinic using what we call slit lamp or a microscope, shining a bright light in your eye and looking through your pupil to the inner lining of the eye and finding out if you have wet macular degeneration or not. And if you did, the doctor or the clinician would advise treatment with an injection in the eye, and then you would be booked a next appointment. And that cycle continues regularly, week on week, and that goes on indefinitely in the current treatment options that we have. Now, it was well and good until last year when the pandemic hit. We had to readjust how we provided the service. And here's the picture of our clinic here at Bradford. So this is our macular clinic. This waiting room would have been filled with the chairs for the patients to be sitting on before the pandemic. But because of the pandemic, we had to readjust with the social distancing and whatnot. So we could have less patients in the clinic at a given time. And here is another waiting room in the same clinic. The 2 doors that you might be able to see is, one door is for the vision assessment, where your eyesight would be checked. And the second door is for that scan for the retina. And after the scan, you would go and visit the clinician, doctor like myself, to assess your eye. Again, we had to reduce the number of chairs in the clinic post-pandemic, and this is our current clinical waiting room. A chart just to remind ourselves that vision can be assessed, and this is the chart we rely on for finding out what the treatment response is for a given patient. So at the baseline, your assessment would be done on the chart similar to this. How many lines or how many letters you read on the chart, that would be documented. After that, your eye would be examined. Here is a picture of the inner lining or the retina of the eye looking straight on at the macula. The middle part is the macula. And in this case, there are a few spots of hemorrhages that you might be able to discern. And that's a telltale sign of something amiss in this macula. And when your clinician notices a spot of blood, like this, very subtle, tiny, that indicates that there may have been a breach in a capillary in that area, a sign of wet macular degeneration. And then you would see a clinical personnel like this one, our research nurse, who would be taking pictures of the lining of your eye, or OCT scan. And as I mentioned, that OCT scan gives us a microscopic view of the profile of your retina. And I've put this picture here. That is the OCT scan going through the center of the macula, where it is thinnest. So that area is about 0.2 of a millimeter in thickness. And that is the area that gives you the best possible vision. And this is a picture from a healthy, normal eye. And I'll show you a picture of an eye with wet macular degeneration. And if you can see the difference in this, there is swelling in the middle. So unlike the thinnest part in the middle, there is a raised a little bulge in the middle. There is a black space within the retinal tissue that is taken as fluid leakage within the retina. And when the clinician looks at a picture like this, they would be able to tell that this is a case with wet macular degeneration where fluid has leaked in, and we would try to reduce the swelling with the injection to get it in a normal shape like the previous picture, the closest that we can. And hence you may have heard that the emphasis now through the efforts of Macular Society, our optometrist colleagues, and the clinician is to try and identify these changes as quickly as possible, as early as possible, and get those patients seen in our clinics as soon as possible so that we can start the treatment early. That gives us a good chance of improving the structure of the macula and then improve the vision as a result. So that's the history then, just before I go on to talk about Beovu, that we have had these two very good agents for injections in the eye over the last few years. The Lucentis was the first one that got licensed. That was marketed here in the UK by Novartis. And the NICE approved its use in 2008. So it's been in clinical use for a very long period of time. But it took another 5 years before we got hold of the next agent called Eylea or aflibercept. That was in 2013 that it got approved by NICE. And it's been used for macular degeneration, diabetic macular edema, and vein occlusions ever since. So thousands of patients have been treated in UK and across the globe where these two agents have improved visual function in a number of them and reduced the progression of vision loss in almost every single case. So what we have learned over the years as doctors and clinicians is that if we get these patients early in our clinics, start treating them with injections, that early good control of the macular degeneration is linked to better outcome. And hence, as I say, the Macular Society has been emphasizing the need for quick referral for these patients in the hospitals. But the problem with macular degeneration treatment at the moment is that it needs regular and sustained retreatments or injections every so often. And so patients require lots of clinical visits over the years of their treatment. The other thing we have learned is the response to the various injections. They vary in each eye. And I've observed that response can be different in the two eyes of the same patient. So it's difficult still to figure out how each eye is going to respond to treatment. Some eyes require very frequent injections, while the other eyes may need less frequent injections and have good visual outcome. So we are still learning from our experience as to how to adjust the treatment for our patients. So when I talk to patients in my clinic, one thing that comes back loud and clear is that, yes, the treatment works, but is that frequency of treatment that is required, that bothers a number of patients, is the burden of treatment, how frequent they need to be in the clinics. The second thing that is we haven't cracked yet is that, yes, the treatments control the leakage, but we haven't found a treatment as yet that repairs the retina or the macula. So the scar which is there can be replaced by a healthy tissue again. And hence the quest continues to find a safe and effective treatment that is user-friendly. And I think most patients, and including me, I would prefer a treatment that I can administer myself in my own time, in my own home, if it was possible, rather than having to come to the clinic and having injections in the eye repeatedly. But we're not there yet. But what we have is yet another agent called Beovu. So the research on Beovu was done quite a few years ago. It takes a long time for a drug to be developed by any company. Years before it reaches the clinical trials. And in clinical trials, it takes typically between 2 and 3 years for the trials to run, and then the results to be produced. So the results of this Beovu agent was published back in 2020, late 2019. And the trials were called Hawk and Harrier. So Beovu or brolucizumab, the agent that is used for controlling wet macular degeneration, it is yet another anti-VEGF agent. So if you remember what I started with, is the VEGF is that chemical or a fertilizer that blood vessels thrive on to grow. So if you mop that VEGF with anti-VEGF agents, you can slow down the progression of the blood vessels. So Beovu or brolucizumab is quite potent in controlling that VEGF in the eye and thereby controlling the progression of wet macular degeneration. I've got a picture of the various molecules that are being used for controlling VEGF, that fertilizer in the eye. The small picture, the purple picture on the left, is a representative molecule of Lucentis. That's the first anti-VEGF agent that got licensed. And as I said, has been in practice since 2008. The next one along is the Avastin molecule. So you can see the size of the molecule in that drug is slightly larger than Lucentis. Next one along, the third one in the middle, the two that look similar, that is the aflibercept molecule. That's the Eylea. So that's slightly larger than Lucentis molecule. And I'll just point out the very last one here is the one we're talking about today, and that's Beovu. So what you see here, hopefully, is that the Beovu is a much smaller molecule compared to the other two anti-VEGF injections we have been using so far. So if you have smaller molecule, you can deliver a lot more molecules in that small injection that we give in the eye. And that, I think, has been very helpful. So we can deliver more of the drug doses in the eye, which would help to control the VEGF levels in the eye for a longer period of time. That was the theory. And that was tested out in those two clinical trials, almost 1,800, more than 1,800 patients were recruited in those trials all over the world. And the trial was comparing the new compound, the Beovu that we're talking about, with the current gold standard, which is the Eylea injections. And the trial was run where patients were divided into various groups. So the groups that received Eylea were, as per the standard license, they got 3 injections to start with, a month apart for the first 3 months. And then they continued to get injections every 8 weeks throughout the trial in the first year. While the Beovu injections, they were given 1 every month or 4 weeks for the first 3 months. And then the group was divided. Either the patients received injections every 8 weeks or every 12 weeks. And when the trial was completed, the results were, the data was analyzed at week 48 or 1 year. And what they found was, when they compared the vision on the charts that I've shown you, there was not that much difference between the groups getting the Eylea injection and the groups getting Beovu injection. So almost similar. So the technical term that is used was that the Beovu injections are not inferior to Eylea injections. So they were similar. When they compared the fluid in the retina, they found that the Beovu patients who received the Beovu injections, their retina looked better for the fluid compared to the patients getting the Eylea injections. And because there was a slight difference in the design or the intervals Beovu injections were given, it was found that more than 50% of the patients getting Beovu injections could be maintained, their vision could be maintained at 12 weekly injections, that's 3 monthly injections. And that was the exciting part. So when this news came to us, we were very excited towards the end of 2019. And we said we would like to have brolucizumab available to us and our patients. So we proposed that to our various committees in Bradford at the beginning of February 2020. And this was before the drug was licensed in Europe. And we were promised that we can start using it in Bradford for our patients, pending the review by NICE. However, we had the pandemic hit us in March, so we could not start using the brolucizumab instantly at that point. But over the period of last year, we started using Beovu for a selection of patients in our practice here in Bradford. And we continue to start treating patients with Beovu where it is appropriate. And as you know, as Kathy has mentioned before, NICE, that's the regulatory body that controls which expensive drugs become available on the NHS, gave a favorable opinion for use of Beovu in February this year. So that would open up the way for Beovu to be available in all eye clinics up and down the country now onwards. So as a result of this, we can start treating patients with wet macular degeneration, those who your clinician would feel are appropriate or suitable and would benefit from the treatment, would receive Beovu injections. Usually it would follow the same pattern as the other two injections that are available, which is giving 3 initial injections every 4 weeks. And then depending on how the eye responds to the treatment, Beovu in this case, patients would get either 8 or 12 weekly injections. We expect that at least half the patients would be getting 12 weekly injections rather than 8 weekly. And as we learned with the other 2 injections, I'm sure we're going to learn further with this injection as well. And we can extend the intervals for these group of patients with Beovu as per the treatment response up to 12 weeks and possibly beyond as well if possible. But just like any other medication, both yourself, the patients, the public, and the clinician would have to weigh up the advantages of brolucizumab against potential risks with the brolucizumab. Now, advantages are quite clear that it is going to give you similar results as the Eylea or ranibizumab as far as the vision is concerned, but it probably would give slightly better result regards reorganizing the structure of the retina or the macula by drying up fluid quicker. Since brolucizumab has been launched in clinical practice, there have been some reports that it may lead to some inflammation in the eyes in some cases. And this is why your clinician need to assess your eye before a decision is made to use brolucizumab or Beovu. At the moment, most clinicians are using Beovu where the other two agents are not providing optimum control of macular degeneration. So that is something to bear in mind. So the question most people ask me in the clinic these days is, should I have it? And the short answer is possibly yes, but it would depend on what your eye situation is like and what your opticians, your optometrist, and the clinician has seen in the eye regards the condition of the macula, how the other treatments have worked or not worked, and what is the situation with the other eye. So all those factors are considered before a decision is made whether the brolucizumab or Beovu would be a treatment option for a given eye or a given patient. And just like any other field, we continue to evolve in research, in our clinical practice. We learn from what we have seen or observed so far and continue to refine the treatments for our patients in future. This is a lovely picture of our research building where we conduct some of the trials, including trials on Beovu. One of the concepts that we have is that research would provide the answer as to treatment options that can become available, but research does not provide all the answers that are relevant in clinical practice. And hence, learning from the real life experience is as important. And then every time I go to the local macular society group meetings, I say that my patients are my teachers. I learn from them, I listen to them, and I reflect. And together, we learn and find better answers. And this is going to be the same case with Beovu as well. But in the experience that we have had so far, over 6-8 months now that we have used Beovu, it certainly is a very useful additional treatment option for our patients. We still need to learn and refine our pathways for our patients. One of the most important things that I have learned is, as a clinician, is that I am here to support my patients. I don't make decisions. We make decisions together. So the patient's involvement at the outset is the most important part. It is important that we ensure that we both understand, as a doctor and the patient, as what the situation is, what the options are for the treatment, and which option would be the best for a given patient or a given eye. So when I write here that it's a counseling that is important, it's not about the counseling about anything else, but about the macular condition, and how it is likely to progress without treatment or with treatment, what it would mean in real life for me as a clinician, my team delivering that care, NHS as a wider organization, and you and your family who would be bringing you in the clinics for repeated examination and treatments. At the same time, I think it's important to remember that any treatment that we offer or undertake has a potential for causing harm. And knowing those potential side effects or the risks are important, because your clinician may be seeing you once every month or once every second month, but in the meantime, it is you would be able to see what you see out of your eye, and nobody else can see that. You would be experiencing the changes in your vision or in the health of the eye that nobody else can explain. And at those times, you need to reach out to your clinical team and explain to them about your concerns or questions, and expect to find the answers from your clinical team as well. So once again, to reiterate, the Beovu has shown that it is going to be an effective treatment option for us in our macular clinics. But it's not going to be that game changer as yet that we're all looking for. Certainly it is an incremental benefit, but my patients, even if they go on Beovu, are still going to need regular reviews, analysis, and regular treatments. Most likely less frequent injection, and that's where its main advantage is going to be. So I would like to thank you all for listening to me. I think it would be better if we try and make this a bit more interactive and answer the questions if you have any, if that is okay with you, Kathy.
That's perfect. Faruque, thank you very much for a very, very interesting talk. We do lots and lots of questions, so I'm going to crack on straight away with them. Just to go back to something you said in your talk about the size of the molecules, and it was very interesting to see the difference, how much bigger some of the other molecules are compared to this one. Just explain to us again, why is that important? We know that the eye and these drugs have to be injected into the back of the eye because the eye is this perfect capsule that is designed beautifully to stop stuff getting from the front of the eye to the back of the eye, isn't it? So that's why the drug has to be injected. But the size of the molecule, can you just help us again? Why is that so important?
Sure, it's a very good question. Now, because the structure of the retina is such that you would want your drug to reach at the bottom of your retina, deeper layers of the retina. So if you start thinking from pupil inwards, we have pupil, then the iris, then the lens of the eye, and then we have the vitreous, the jelly in which the injection is given. And beyond that jelly, the lining inside the eye is the retina. And with macular degeneration, the problem arises in the deeper layers of the retina. So the molecule or the drug that is sitting in the gel has to grow through all the layers of the retina and reach in the bottom of the retina. And hence, theoretically, if you have a smaller molecule, you would have a better penetration through that retinal layers and reach the deeper layers of the retina. And the second part, that's the penetration part. And the second part is because it's small, you can pack in a lot more molecules in that small volume of fluid we're putting in the eye. And that's why it can block a lot more VEGF and have that more efficient, potentially more efficient mechanism in controlling the fluid. That's the theory.
So it's very interesting because, of course, ideally we want eye drops for this drugs, but we can't get the drops to the back of the eye. This is obviously a condition. It'd be lovely if we had a tablet you could take for it, but the drug doesn't get to the back of the eye. It needs to be absolutely where those blood vessels are being are growing. That's where and leaking. That's where the drug needs to be delivered, right to that spot, isn't it?
It needs to reach there, and you're spot on. We have done research projects where we tried out the drops, the early stage research, and it is promising, some positive results there. But you would need a lot more molecules, a lot more drops delivered on the eye to reach that concentration at the back of the eye. So it won't work instantly like the injections work. That's one of the drawbacks. There are other options of delivering the drug at the back of the eye. People are trying different routes, like going through the back part of the eye. But again, those research projects would need to come to fruition before we find out which route we can find, which is going to be better than the current route.
Okay, so let's move on to some of these other questions then. So the trials, what we call the pivotal trials, the ones that really lead to the approval of these drugs, only compared Beovu with Eylea. Is that right? So there isn't a direct comparison. Is there a direct comparison with Lucentis, or do we only have a direct comparison with Eylea in terms of which is best?
So the pivotal trial, the Hawk and Harrier, were the comparison between the Eylea and Beovu. I think most of the trials have switched from Lucentis to Eylea as a comparator now, because that seems to be the gold standard of treatment currently. With the comparative trials between Lucentis and Eylea, there was slight marginal difference in favor of Eylea. And hence, if you find that your drug, the new drug, works as well as Eylea, it is given that it would be working as well as Lucentis as well.
Right. So several people have asked a question about if they're already on Eylea and maybe already through this sort of treat and extend mechanism, trying to extend as far as possible safely the intervals between drugs. If they go beyond that, or even at 12 weeks, how are their eyes monitored in between? So the question is, what happens if my sight goes? That's a long time, isn't it, to wait for it between injections? So what's the thinking about monitoring eyes in between these 12 weekly injections for Beovu?
Sure. So I'm sure the members who are listening to our talk today would have experienced that when you go to clinics, your treatment intervals are increased very gradually based on how your previous visit has looked like. So if it shows that you have had good control of your macular degeneration activity, only then the clinician would have extended the interval. And they would keep on doing that until they find that there is a recurrence or the activity comes back, and then the interval would have been reduced. So if that has been done safely, the consensus is that usually there is no need to monitor for that safe interval that has been found clinically. And it would be the same practice that would be followed for Beovu as well. As long as we figured out at how long the drug controls the macular degeneration in the eye, be it 8 weeks, 10 weeks, or 12 weeks. And that is the interval the patients would be maintained for that injections. But again, as I mentioned in my talk as well, the importance is to understand what are the signs that an individual patient need to look out for that are concerning, and they need to have that access and confidence that they can access the clinicians or the clinical team to report that change. And they can be fitted in earlier in the clinical system as a result.
So always be aware of your vision and any changes in the vision, no matter how long really you're going between injections, I think.
Yeah. So if you any doubt, I think the best is to check again.
So you mentioned this inflammation issue. So there has been quite a bit of a flurry over inflammation and Beovu. One questioner says she was told it wasn't worth the risk for her, a 4% risk of having inflammation, and she was advised it wasn't worth taking that risk, presumably because her condition is being very well controlled by the drug that she's on at the moment. But is the risk of inflammation radically different for Beovu versus the other two drugs, Eylea and Lucentis? Normally, is there much difference?
That is interesting. So when the trial results were published and when the drug got licensed, the licensing authorities looked at the risks between the groups, and they came to conclusion there was not that much difference between the groups getting Eylea and groups getting brolucizumab or Beovu. But as I mentioned, any clinical trials looks at a finite number of patients, and a lot more patients are going to be treated after the trials. So if there is a smaller signal for side effects like inflammation in this case, is not going to picked up by the trial itself. So when a lot more patients were treated with Beovu in the United States, that's where a couple of dozen of patients were found to get inflammation in the eye. So inflammation in the eye is not a big issue per se If it is only mild inflammation, that can be controlled. Sometimes it settles on its own, sometimes controlled with the drops and it goes away. But the issue, however, here is if in severe cases of inflammation, it causes what we call vasculitis or inflammation in the blood vessels in the retina. In very small number of cases, 0.5% of the cases with inflammation in the blood vessels, that led to loss of vision. Now that 0.5% is more than what we have observed with the existing injections, Eylea and Lucentis. And hence we are selecting our patients very, very carefully and making that decision in conjunction with our patients, like the lady that you mentioned.
So is this higher level of inflammation linked to the higher level of drug that's being delivered then? Is that possibly why this is happening?
It is not completely clear. It may be one of the factors. People have questioned that, but there is no conclusion evidence because the numbers are still small. So what we need to do is we need to learn from all these cases that have come forward with the inflammation. What we have learned, however, is that if the eyes have had inflammation before, those eyes with history of inflammation, they are at a higher risk of getting inflammation after these injections. So we need to make sure that we exclude the eyes with inflammation from getting Beovu injections at the moment.
And presumably, by the same token, then patients who are doing well on Lucentis, for example, or like Eylea, and already at 12 weekly intervals, would there be not much point in switching those patients if they're doing well at 12 weekly intervals for Eylea?
That is my clinical opinion as well. So because it doesn't give you any additional advantage over that, either visually or from the structure point of view. So if your macular degeneration is controlled with the existing agents, and you're happy with the intervals at which you're getting those injections, there's no point switching it to the Beovu injections.
Right. Now, you mentioned that NICE approved this in England and Wales earlier this year, and I think it was approved in Scotland a little bit before that, wasn't it? I'm not quite sure what the situation is in Northern Ireland. Normally they follow NICE, don't they, at the moment, I think.
So Scotland, SMC is the body that approves the agents in Scotland. And I think the approval from SMC was around October time last year. And ever since it's been available in Scotland. So they have been ahead than England and Wales in treating patients with Beovu.
So how quickly will it be available everywhere, do you think? Will we see this postcode lottery for a little while different clinics take it up at different times in different speeds?
There is some variability in how this becomes available in clinics up and down the country. But my understanding is the requirement is post-NICE approval. The commissioners have about 3 months to start approving the use of Beovu in clinical practice. So it's been about that time, so it should be available in most clinics by now.
And a little question that has come in about switching generally. Lots of people, I think, are switched between Lucentis to Eylea. Lots of people have been switched during COVID to Eylea, haven't they? Because it lasts. Lucentis. Some people have switched from Lucentis to Eylea and then back again if Eylea doesn't work as well. What's the sort of rule of thumb for deciding on switching somebody? At what point do you say, okay, this isn't going so well, I think we need to try something else?
Very good question. We got together as some retina experts a few years ago and try and answer this question. And what we rely on is the treatment response. And treatment response, we look for two things. One is how the vision is seen to change with injections. And the second is the structure or the OCT scan, the appearance of macula, whether there is a persistent or fluid or not. It's a combination of these two things help the clinician to decide whether the treatment response is optimum or not optimum. And then the discussion needs to take place with the patient as well in deciding whether we should switch the treatment or not. One of the slight issue with switching is the expectations may be different for the clinician and for the patients. Most research studies that we have looked at the switching treatments have found that the switching treatment does not make a big difference to the vision. It makes a difference to the structure and the frequency of injections patients need, but it not automatically improves the vision that much. So that is something to bear in mind.
Do all these drugs decline in effectiveness over time? Is there a tail off of efficacy over time? Do we know that yet?
That's a very good question. Overall, I think both Lucentis and Eylea have stood the test of time. And most patients, I have patients in my clinic who started treatment back in 2008, still attending, less frequent injections, but still you see the same efficacy of the treatment, and the treatment response is still pretty good. So not all patients lose the efficacy of treatment. There is a small subgroup of patients where you lose that efficacy slowly, something that's sometimes described as tachyphylaxis. Sorry to use that big word, but all I'm trying to say is to reassure our patients and your listeners is that the injections are still very effective even after years of use.
And for patients for whom Lucentis doesn't work, Eylea hasn't worked, is there any expectation that Beovu would work for them? Does it work in a sufficiently different way? Is it sufficiently different to give hope to people who've tried both of these alternatives already?
Sure, it certainly is an option. Now, it's something that we have observed in clinical practice. There was no clinical trial of switching Eylea or Lucentis patients onto Beovu, but in clinical practice, by doing that, we have found that it is effective in controlling the macular degeneration activity. So yes, it is a good option.
And there are some people, I think they're sometimes called not meaning to be rude at all, but frequent flyers, aren't they? People who have lots and lots and lots and lots of injections. For people who need a lot of Lucentis injections to keep their vision stable, or who might have been having 80 injections, one person has just said on the 84th injection of Eylea tomorrow morning, would that be a case for looking at Beovu?
It's a very good question yet again. And my view is that if your macular degeneration is well controlled with Eylea, injection number 81, I would continue with injection number 82 and 83, 84, rather than switching it to Beovu, because we have found that Eylea works for your eye. And when we switch it, we would need to figure out whether Beovu would have similar at least or better effect or not. And using Beovu is not going to reduce the number of injections you're going to need in future either. Maybe a small difference. So if your injection frequency is not more than every 8 weeks, I would continue with Eylea injections.
Okay, thank you. So just a number of questions about other conditions and whether Beovu is being considered for other eye conditions. So one patient has angioid streaks, another with myopic CNV, choroidal neovascularization, DMO, retinopathy of prematurity. There are lots of similar conditions, aren't there, that other drugs are used for. Do you think Beovu is being studied for these conditions as well as AMD now?
So the current trials that we engaged with Beovu are, one is on DMO, and there is a trial on retinal vein occlusion. Angioid streaks are rarer conditions. Myopic macular degeneration is rarer compared to age-related macular degeneration. What we have learned and found previously is that the drugs that work for age-related macular degeneration, like Lucentis and Eylea, they also work for myopic macular degeneration and for angioid streaks as well. But again, we don't know whether it's going to be a better treatment options than the existing treatment options for those conditions. But my presumption is that it would work in those conditions as well, but there are no trial data to back it up as yet.
As yet, but it's quite possible that they will look at that once they've got the AMD people through. They often turn, don't they, to these slightly rarer conditions and look again. So a question just has come in about does treatment vary in parts of the country? And I think the answer is it shouldn't vary that much, but it will vary a little bit, I think. Does Beovu cause fewer floaters? So obviously a patient who has a lot of floaters after injections. Is it any evidence on floaters yet?
The common floaters that we talk about is the debris within the vitreous. Should not be any different whether it's Beovu is used or Eylea is used. I'll put a caveat in here because we touched upon a potential side effect of inflammation. And if the inflammation takes place in the back of the eye, the vitreous, the jelly of the eye gets more debris. So in cases of Beovu with inflammation, you get more floaters. And that's one of the signs we ask patients to look out for. So apart from that inflammation-related increase in floaters, the incidence of common floaters won't be much different in the Beovu eyes or Lucentis or Eylea eyes. So there is no advantage of switching to Beovu for floaters, certainly not.
Somebody's raised a question of price of this new drug. Now, we know that Lucentis and Eylea, when they were launched, were very expensive drugs. And we know that the NHS spends about £500 million, I think, on anti-VEGF drugs. Is this competitively priced, or is it carefully priced to be about the same?
It's a good question, but I'm not privy to that information. My understanding is that the company has entered into that special arrangement with NHS. So the prices would have been comparable, I would have thought, because the NICE would not approve any drug that is going to be costlier or does not meet that economical model for cost effectiveness.
And just before we finish, because we're just about running out of time, just a couple of people have asked a question about diet, exercise, anything that they can do to prevent progression of their condition in terms of lifestyle. Just a word on that would be helpful, I think, to some people.
Sure. So I think good, healthy lifestyle is useful for overall health of the body and also for the eyes. So healthy diet certainly is very good. Avoiding the risk factors like smoking certainly is good. Red meat is not nice, as we all know, but oily fish are good. Now, we have heard about the clinical trials on nutritional supplements, and there are mixed messages that we have learned from that once you have had the wet macular degeneration, you already have entered into that advanced stage of the disease. At that stage, the nutritional supplements beneficial effect is already gone. So we should be talking about beneficial effect when there is early stages of macular degeneration. And the nutritional supplements help preventing wet macular degeneration more than progression of the dry macular degeneration. So certainly is an option that we can look into, but overall, just look after your health, healthy diet, avoid smoking, simple measures, they're more effective than more expensive ones.
And just finally then, before we finish, a couple of questions about pain. So a few people have said that they have very painful injections because the anesthetic doesn't seem to work for them. This isn't an uncommon thing that we hear, actually.
Sure, and there is a variability as well. So once you have had quite a few injections in the eye, clinicians, if you feel comfortable, you can suggest to your clinicians as well. Usually clinicians do, which is to change the site of the injection from left to right. So the injections don't go through the same part, that might help. Or having additional anesthetic agents applied before the injection, that can be useful. But yes, from time to time, it can be a little bit uncomfortable for some patients.
Well, some people say more than uncomfortable, but I'm not sure quite what the alternative might be other than more anesthetic, or as you say, changing the site of the injection.
Sure. I think so far we haven't needed that. Most patients get just the drops to anesthetize the surface of the eye. But there are other ways of anesthetizing or numbing the eye, which could be giving anesthetic injection to numb the eye if it is really, really painful and they can't tolerate the intravitreal injections.
So people need to have long conversations with their doctor, don't they, about how
Correct. So it needs to be tailored to the eye and the patient.
All right. Well, we've sadly run out of time. We're 2 minutes over. So Faruque, I just want to thank you again for joining us tonight. It's so kind of you to give up your time. I'm so grateful to everybody who has joined us this evening. If you want to hear this again, it will be on our website in a day or two, and then you can, if you missed something, you can have another listen, or you can signpost other people to it and pass it on to other people if they if you think it would be useful to them. Our next virtual clinic will be on the 3rd Tuesday of June, when my guest will be Dr. Greg Hagerman. He's a leading ophthalmologist from the United States, and he practices and studies and researches in Salt Lake City. And he'll be talking to us from his laboratories in Salt Lake City about the work that he's looking at the genetics of AMD and the possibility that AMD is not one disease, but in fact, maybe at least two and possibly many more, at least differentiated by the genetic differences. Greg has this enormous repository of eye tissue in Salt Lake City, and his research is leading much of the thinking on the origins and potential treatments of AMD. So he'll be joining us from Salt Lake City next month as our guest. Faruque, thank you very, very much indeed for your time today. I'm so grateful to you. Thank you to everybody for joining us, and I look forward to seeing everybody again next month. Thank you very much indeed, and good night.
Thank you and good night.